I go through a lot of different the development stage about Invisalign, and also I meet with a lot of different maybe some problem or the new technology, and yes, okay. So today I will share some cases for you. Okay, I think, of course, in my clinical practice, many different complex malocclusions, of course, we will meet. Maybe class 3, maybe class 2, and maybe mutilated dentition, etc. But I think if we want to learn more about treat the complex case with Invisalign, I think bimixal protrusion dental bimixal dental or filler protrusion treatment, it could be very important to most of the dentists. Of course, in Taiwan, maybe the same as in Malaysia or another Asia country, we will meet a lot of cases by bimixal protrusion, and this patient, they hope to retract their the lip to more flat and straighten anterior teeth. The Chinese and the Caucasian, there are some different in skeletal. Sorry, I have to close. Information, please. Okay. Okay. And first, let's think about there are some different with Chinese and the Caucasian. According to 2002 Australian Orthodontic Journal, they compare the Chinese and the Caucasian. There's a different in skeletal, in dental, of course, in soft tissue, and in skeletal. They are in Chinese, the cranial base is shorter, and the AMB angle is more larger. In dental, many Chinese people, they have greater bimixal or filler protrusion and acute interincisal angle. And in soft tissue, because of the less prominent nose and the obtuse nasolabial angle, it will make their profile more retrusive. But when we face a lot of different bimixal protrusion, we have to think about what kind of the bimixal protrusion is more easy, or what kind of bimixal protrusion case is more difficult, more challenging. I divided the different treatment triage according to the interincisal angle. If the interincisal angle is less than norm, or interincisal angle is more than norm. If less than norm, I think this case could be median. The challenge is median. And interincisal angle is more than norm. That means this case could be very tough, because we need notice more about the root top control. In this case, interincisal angle less than norm, we just only think about how to make an anterior teeth tipping or a little intrusion, and to make the maximum increase and the posterior teeth translation, and it could be very maybe you are not so many experienced, and if you face this case, it could be very more easier with you. But if you find out the interincisal angle is more than norm, I advise you take care, because you have to think about more torque in anterior teeth, and most of the time they have gummy smile. So as I said before, if you want to break through the treatment limitation with clear aligner, I think you have to try to treat bimixal protrusion, because this case would be the first stone for you. And today, I will show you 6 patients, and these six patients, all is bimaxial protrusion, and they have different problems. So from this case, we could understand the sound problem and how to overcome this problem. Today, I show you this case, but that means maybe you will meet this problem. You will meet some difficulty. I told you some rule, not because I will let you to avoid this rule. This is impossible. Every dentist, everyone, you will meet this problem every day, all the time. But you have to know how to treat this problem. From here, this case is deep protrusion and chip complaints, gummy smile. Okay. Would you like surgery? Of course. I told this patient, hey, Miss Chu, please, I think you have to consult the medical doctor for the surgeon. Of course, he refused because many patients, they are afraid of the orthodontic surgery. So, okay, I can try for you, but I cannot guarantee that we can treat as you think. Maybe you want to make the superstar, the Halloween superstar. I'm sorry, I cannot to make you become a superstar. I just treat your teeth. Okay. And from the saprophometric analysis, we can see first the APDI, ODI, this index, we can see the skeletal pattern is skeletal class 2. And this is a very important index. Is upper one to facial, the FH plane, and the upper one to SM plane. We find out normal upper incisor inclination. That means this angulation is very good. So if you retract anterior teeth, sometimes it will make retrocline much more, and it will become worse. And we can see the interincisor angle a little. The degree is a little acute. That means we have a little space to retract or more upright anterior teeth. And from the skeletal pattern, and we find out it a little skeletal class 2 open by tendency. So from saprophometric information, I make this treatment plan. I removed the upper bicuspid, first bicuspid. And in lower arch, I removed the second bicuspid because I think the canine is class 2 and a little midline deviation. So I worry about the lower anterior teeth will retract much more and make the upper jet become worse. Okay. This case, I use the braces. And today I start a case from the braces because I hope you all to understand the mechanics. The braces will make us easy to understand the treatment mechanics. So here, I use the double power arm in the mesial and between in the mesial and distal side of canine, and pulling the power chain to the text. Whether you want to treat any kind of bimaxial protrusion, we have to know if they are not used tests, you cannot get maximum anchorage. So test is very important. I think the test is a significant milestone for bimaxial protrusion treatment. Without test, let me remind, in the past, we used the extraoral anchorage, maybe the face ball, maybe anything else. But when the test to be used, we get the true maximum anchorage. But use the test, we have to think about the test position, direction of force, and the strength of force. In 2017, this paper, it talks about the retraction force or intrusion force, the MS retraction or intrusion, we need 212 grams per site. Actually, I don't think we need so much the pulling force. Okay, but from this paper, we can check the very important idea is the test position and the power on position. And from here, I know many doctors, they will put in the test between the molar and the premolar, and then putting elastic from the wire to make the anterior teeth retraction. I know many doctors they use, but I recommend never do it, because if you make the pulling force from the wire to the test, it will very easy to make anterior teeth extrude and retrocline. So most of the time it will make your bite become deeper. So if we like this, if we use this idea in figure A and figure B, we will make the pulling force more close to the center of resistance. I think it could be better for you, for everyone. This paper is 2017, but I used the idea in 2014. I know if I can make the we can make the force factor more close the center of resistance of the anterior segment, I will make a good torque control in anterior teeth. And another, I recommend you use the more simple mechanics is loop mechanics. The more simple mechanics applied, less unwanted effect caused. So I don't like to use a lot of very like T loop or another L loop or very complex loop. The more design, the more unwanted effect will lead to. So I always use the loop mechanics. The loop mechanics were made by 016 by 022 stainless steel wire. And they have some good points. First, the loop mechanics, they offer persistent force. And it's very easy to wire bending, very easy. Monkey can do it. Oh, just a joke, sorry. And of course, they will reduce the soft tissue irritation, because if you use the L loop or T loop, it's not easy. In the patient's cheek, the patient will complain, the mouth always over ulcer. It is very uncomfortable. And I decided to meet with my patient uncomfortable, because he will call me and complain. And patient not happy, and I will be not happy. And of course, the loop, we can easily pull in elastic to the text. The fifth point is, I think is the most important, is the loop, it will offer better torque control. To treat the bimexia protrusion, we have to know better torque control is a key point. Okay. And besides the anterior teeth retraction, we have noticed this patient, he hoped to correct the gummy smile. And how to correct the gummy smile treatment? The best position of screw to most of gummy smile patient, we have to think about the position, the head, and the force. And here, I always put insert text between canine and the incisor, not between incisors. And I never use the incisor in between the central incisor, because the text in the central incisor is very uncomfortable for my patient. And screw head exposure less than 2 millimeters. Of course, if the screw head exposure more than more than 2 millimeter, maybe 3 millimeter, the patients complain. And the height from main wire to the screw head is around 8 to 10 millimeter, like this. This length will make us easy to use the power chain and pulling the anterior teeth to achieve effective intrusion. Okay. Please notice, I know many doctors, they will use the teeth in posterior teeth, posterior segment to make the anterior retraction. And at the same time, they will use the teeth in anterior teeth to make the incisor intrusion. But I recommend you do not dislodge and intrude simultaneously. I think I always separate it. I always finish the anterior teeth retraction to the normal overjet and then start to intrusion to correct gummy smile. Because when we retract anterior teeth to make the arch dislodgation, we will make the molar tip back. And this molar will produce the clockwise rotation, clockwise moment. But at the same time, if we put in the elastic from anterior teeth to the central teeth, we find out counterclockwise moment. And both of these moments, they are counteract. So sometimes we will find out the dentition cannot to make the dislodgation. And we only find out the anterior teeth buccal tipping and intrude. And we will find out the overjet become much more. After our treatment, okay, let's take a look here. The loop mechanics is very easy to pull in elastic to the teeth. And finally, we achieve the midline coordination and the class 1 occlusion and the solid occlusion. But the important is we correct the gummy smile. This patient is very happy. And let's check what happened in cephalometric X-ray. Okay, the anterior teeth retract, and the lower anterior teeth and upper anterior teeth retract much more. But we find out the molar position is maximal anchorage. From this case, our treatment conclusion. Teeth position, I always use insert teeth in canine, between canine and incisor. And in posterior segment, I insert the teeth between first molar and second molar. And I always keep the heads of teeth close to gingiva, maybe just exposure to 2 millimeter. And the intrusive power chain applied as vertical as possible to correct the gummy smile. And the wire loop length is 10 to 12 millimeter because the wire loop length, this head will make the force more close to center of resistance and keep the power chain at the same level with spool loop heads for dislodgation. And final, power chain you can replace every week because the power chain decays very quickly. Okay, so Dr. Mulligan is a very famous dentist, famous odontist. In 1979, he published the Common Sense Mechanics. At that time, many orthodontic appliance or mechanic is very complex. But I think Mulligan is genius. He used a very simple idea to explain the complex orthodontic mechanics. After after 5 years, after 50 years today, we still can use this idea to explain the aligner. So last year, I have a special lecture about common sense aligner mechanics. And I use a lot of Dr. Mulligan's the common sense mechanics ideas to explain about the aligner mechanics. In the common sense mechanics, he talked about the common effect when leveling. The first is the roller coaster effect. Roller coaster effect will make the overbite become deepening. But it often find out in extraction cases. And second is roll effect. It will make anterior teeth proclination. This often find out in non-extraction cases. When we start to talk about how to use the clear line to treat the bimixal protrusion cases, we have to understand the advantage to use clear aligner, and we have to understand the accuracy and the efficacy. From 2009, 2014, 2019, 2020, and 2021 till today, there are many public papers to talk about the accuracy and the efficacy of a clear aligner treatment. And from this paper, 2019 Korean Journal of Orthodontics, and he made a systemic review, and we just think about the conclusion. The first, okay, maybe when we read this conclusion, everyone can think about this conclusion is the same as my experience. The first, vertical movement and the dilatation are difficult movement to accomplish with a liner, especially canine, of course, because the canine is round like a cone shape, so it's not easy to make a dilatation. And the anterior teeth is more easy. And the second, the program movement is not fully accomplished with the Invisalign, of course. Clean check design sometimes is not 100% the same as you achieve the result. Root control with fixed appliance is much better. I agree with this conclusion. Yes. Root control, especially the molar root control and the upper anterior teeth root control, I think fixed appliance is much better. Fourth, clear aligner therapy, the majority of movement occur during first week. So you know, we change the clear aligner every 7 days. But I think it depends upon what kind of your cases. Not every case you can change every 7 days. Sometimes you have to extend the wearing time, maybe 10 days or 2 weeks. The last conclusion, buccal-lingual inclination and occlusal contact are worse with Invisalign. I disagree with this conclusion because I think a liner is much better in buccal-lingual inclination than braces. But occlusal contact, I understand, because everyone you will meet with the posterior open bite when treating with clear aligner. I understand. So I want to let you know my trick to solve the posterior open bite. The first is segmental power up. This is a hybrid align wire technique. We can combine with clear aligner therapy and the local braces to have better root control. Every appliance, they have their of course, they have their the good point and their disadvantage. But to the orthodontist, I will use this appliance the advantage and that appliance the advantage, and to combine and to achieve the better result. Do you agree with me? What is segmental power on the mechanics? When we wearing aligners in extraction cases, we change the liner every 7 days or every 10 days, and then we find out what happened. Molar mesial tilting. So at this time, we can use the local braces. I bound in the braces, and of course, I will change the angulation of the bracket over the tube in the molar, and I put the wire in the upright, and continue to make it upright. But we can find out what happened. First, the molar will more crown uprighting distally, and the root top is not so. The root top is just a little bit, and we can find out the applied force also will applied on the premolar, and we find out the premolar root top distally. So another choice is signal power arm. It's like this one. I bounded a button, a racing button on premolar and the molar tube. And the same, I bend the wire and like a hook, and then make the power arm to brace the button. And this applies will offer more crown tipping and more root torque. And the to the premolar will less root torque. But of course, sometimes you will make the premolar a little intrusion. So when we use the seminal power arm, we have to combine with the interarch elastic, and the side effect will disappear. And use the signal power arm is for to produce a nerve the counter moment. But how about the Invisalign? Invisalign, the G6 protocol, they use the optimize the anchorage attachment, optimize the retraction attachment, and another aligner activation, and to produce the counter moment. This is the G6 ideal. And I used this idea to treat the bimixal protrusion case in 2015. And I get a very nice result. So I published this paper in 2016. I think maybe this is the first published use the G6 protocol to treat bimixal protrusion paper all over the world. And in this case, let's discuss this case. This is a bimixal protrusion. According to the self-analysis, and we can see the skeletal class 2 and the hypodivergent, and the procline. You see a lot of red words. That means the upper and the lower anterior is very severe procline and acute interincisal angle. And as we said previously, when the interincisal angle is acute, I think this case is median case for most of the doctors. So in this case, I removed for first bicuspid. And of course, for producing maximum anchorage, I combine the tests, no test, no maximum anchorage, and the G6 protocol. And here, this design, is a caterpillar motion design. And in this design, we can find out after 7 months treatment, the space between anterior teeth. And we also find out, even we use the G6 protocol, what happened in the molar? Molars remained mesial tipping. So here, let's think about the anterior side and the posterior teeth need control tipping and overcorrection. About control tipping, in 2017, Dr. Tommaso Cassoflorio, I know he has ever been a special lecturer in Asia, and in Turin University, they use the finger end model to study when we use the aligner, the force, the factor. From the figure A and the figure B and the figure C, we can see whatever you use the attachment or optimize the attachment, the force will make the teeth a little intrusion. And of course, if without attachment, not only intrusion, they will make the teeth tipping. But in the figure D, we combine with the class 2 elastic, it will make the force, the teeth more easy control and the body movement and a little extrusion. So from this paper, we understand if we can offer the class 2 elastics, we will make control tipping more easy. Okay, after 14 months treatment, we find out molar uprighting finish. So in this case, I use the caterpillar motion design and the short class 2 elastic over counter moment. What is a caterpillar motion design? You can name it frog pattern or stage retraction. But I think, okay, let's watch this movie. I think the movement is similarly with the caterpillar motion. You check here. Once again, you'll find out the movement is almost similar. So I call this movement is caterpillar motion design. I decide to use the frog pattern. Maybe sometimes you can use a stage retraction in your clean check. Why we use the caterpillar motion design? According to the biological mechanics of tooth movement, as we know, the tooth was surrounded by the transeptal fiber, and the transeptal fiber is made of collagen. And the half-life of collagen, of native collagen in PDL and in attached gingiva is 40 to 80 minutes. It's a very short duration. That means when we keep if we keep the moving teeth and the PDL in place enough time, and we will make the PDL recognition. So that's why I told you, I recommend you, especially the beginner or if your case is not so many cases, and you want to try to use the extraction cases, I recommend you use the caterpillar motion design and let the anterior teeth or canine movement and stop, and make it enough time to cook, and let the aligner force expression enough. So after 16 months treatment, we finish this case. And from the cephalometric X-ray, we correct acute interincisal angle. And from this case, the keys to success is, first, this is a juvenile patient, and second is highly compliant. A little mild anterior open bite is more easy. So this is a median case, and the acute interincisal angle. And of course, I use the test and the caterpillar motion design to produce the good result. And there are a lot of paper about the bimixal protrusion, bimixal dental alveolar protrusion publication. I have ever write 3 publications in 2016, 2018, and 2009 in Journal of Aligner Orthodontics. And also, I find out the 2020, Dr. Chris Chang, he also published the APO in APOS about the treat bimixal protrusion and gummy smile with a clear aligner and the screw. So I think maybe you can search this paper and to read it. Okay, in 2018, in this case, I will show you the class 2 malocclusion treatment. This case is retruded mandible, and we can find out irregularity anterior teeth and the midline deviation. And also, we find out the discolored teeth in the second bicuspid. So from the OPG and the cephalomaxic X-ray, let's check the wave shape analysis. Okay. From the shape analysis, we find out this case is retruded mandible. This is a typical class 2 bimixia protrusion, and the retruded mandible. It is more difficult. And second is angle class 1 malocclusion. And the overjet is about 7.8 millimeter acute interincisor angle. And the upper anterior teeth is straight. I always advise you all, please notice the upper anterior teeth angulation. If the upper anterior teeth is more straight, much more straight, please think about more torque control. And the second bicuspid is discoloration, and another teeth is 90-degree rotation. So according to this analysis, I decided to extract upper and lower second bicuspid, not first bicuspid. And second, I use the upper arch maximum anchorage and the straighten anterior teeth. I hope to straighten anterior teeth and prevent from the incisor retroclination. Of course, because this case is a little skeletal class 2 skeletal pattern, so I don't want to make this the lower arch produce the clockwise rotation to make the lower facial height become worse. So I also hope to retrude the lip position. Okay, let's take a look at this the clean check design. In this case, I use the simultaneous movement. I don't use caterpillar motion design. Yes, because I hope to try. Sometimes I hope to know that is there any difference with the caterpillar motion design or simultaneous retraction? So in this case, let's look at it. In 2017, ankle orthodontics, Dr. Solstan, he talked about when we use to treat this case with clear aligner, we have to always think about build necessary compensations. Please remember, build necessary compensation. That means we will make much more the reverse curve speed. So in this case, let's think about the reverse curve speed. This is not the new term. This is the old term. In clean check design, I set up the reverse curve speed in clean check. And if the embraces, Dr. Mulligan also talk about this idea, because this is a good concept to prevent from the roller coaster effect or bone effect. This is very important. So let's look at this case. At the 8 months treatment, we also find out molar mesial tilting. So at this time, I use segmental power arm to correct the molar here. When we use the segmental power arm, don't forget to use the class 2 elastic, and it will offer the low molar upright and prevent from the premolar intrude. So after 15 months treatment, we find out the molar upright finish. And let's compare the initial treatment and after 15 months treatment. We level the upper and the lower incisors. And we also use the segmental power arm to upright the posterior teeth only half one year, 7 months. So segmental power arm is very useful to use to solve this molar mesial tilting. And then we go through the first additional liner. In upper anterior teeth, I take the A/2. That means I intrude lateral incisor, then I intrude central incisor, and then I intrude canine. This I named it A/2, a liner by 2. It looks like a 2x4 or 2x6. Okay. After 19 months treatment, after 24 months treatment, we go through the second additional liner to make the posterior bite occlusal settling. I think in upper anterior teeth, the stage intrusion is work. If you intrude 4 incisors at the same time, I think it doesn't work. After 32 months treatment, we almost finished this case. And the final additional liner. So after 32 months treatment, we make the anterior teeth straight and retract the anterior teeth. And from the cephalometric X-ray, we correct the upper and the lower lip, make it more anterior teeth more straight, and I achieved the maximum increase in upper and the lower molar. From the profile, we have a very nice result for the patient. And I use the E-line to check the lip is in contact with the E-line. And sometimes, some doctors, they think about 4 bicuspid retraction to retract anterior teeth may cause nasopharyngeal airway constriction. Is it true? Or do you believe it? Of course, you can find out some different articles. Some doctors, they support the 4 bicuspid retraction will constrict the pharyngeal airway space, and some doctors, they opposed these ideas. And from this paper, the retraction case and the retraction anterior teeth about the airway space, this sampling is for 12 and 18 years juvenile and 150 patients, and they are all 4 bicuspid retraction bimesa protrusion case. The result, the conclusion, retraction anterior teeth would not affect nasopharyngeal dimension or total airway length. So let's look at this case. This case is 12 years old, they have class 1 bimesa protrusion. And from this case, just a little crowding. From the cephalometric X-ray, this is a skeletal class 1. And the upper incisor and the lower incisor is procline. So this case is I think it's also median case. So here, I removed upper and lower second bicuspid, and I designed the clean check. This is caterpillar motion design. And I also use the compensating curve. So you can find out I disocclude anterior bite finally. After 8 months treatment, what happened? We find out roller coaster effect. Maybe you will think about, hi, Stephen, I think the clear aligner therapy is very easy to have the roller coaster effect. Of course not. Let's take a look at this paper. This is the 2021. This is a new paper. And this paper is talking about how to treat the roller coaster effect with braces and in deep bite cases. And here, they designed very different mechanics to use a wire and to use a TEDs and use an interarch elastic and of course the big reverse golf speed to produce the roller coaster effect. So that means roller coaster effect not only happen in clear aligner therapy, it usually in braces, of course. And in this case, after 8 months treatment, this is a typical roller coaster effect, the molar mesial tilting. And the curve speed, deep curve speed. And then we can find out the ejection space is close, but the angulation is not so good. So we start the first refinement after 8 months treatment. And I always do design the class 2 elastic. After 13 months treatment, I combine what? Segmental power arm. After 16 months, we make the molar upright. And when we upright the molar, we can find out the overbite decreased. And after 16 months treatment, after 8 months treatment, it's very different. From the panoramic X-ray, only 8 months, we can use the segmental power arm to upright the posterior teeth. And then we go through the refinement. Because I hope to decrease the overbite much more. After 24 months treatment, after 29 months treatment, we finish this case. We achieved the beta occlusion and then we achieved the midnight coordination. And then we achieved beta profile. And then let's take a look at this the nasopharyngeal airway. After we retract the anterior teeth, the nasopharyngeal airway is still remain. So I agree with the conclusion, this paper. Retraction anterior teeth would not affect nasopharyngeal dimension and the total airway length. And from this case, we also find out growth. So let's take a look at the OPG. After 8 months, we produce a roller coaster effect, and I use a spot technique after treatment, 16 months treatment, we upright the molar, and finally we straighten the root angulation. In this case, is 11 years old adolescent. She is also class 1 bimaxillary protrusion. And from the cephalometric X-ray, we find out that this is a typical skeletal class 2 pattern. and the lower incisor position is normal, is straight. IMPA is 90 degrees. But the interincisor angle is proclined. Okay, from this case, we can find out first, this is the good point is this is a young patient and with growth potential. And second, this case is highly compliant. And she has a little anterior open bite. It's the same as our previous case. If you find out the anterior teeth is a little open bite, and you have to retraction the bicuspid, please try it. It could be very easy for you. And acute interincisor angle. But in this case, we also have challenge points. First, gummy smile. Gummy smile is very, very difficult. And in this case, would you like to use the test in the central incisor to treat his gummy smile? Not at all. And the skeletal class 2 pattern in this case. The intraoral photograph class 2 skeletal pattern and the skeletal open bite tendency and the dental class 1 malocclusion. So in this case, I removed 4 first bicuspid. Okay, let's take a look at this clean check design. The left side is initial malocclusion. I also use caterpillar motion design. And of course, I hope to produce maximum accuracy. So I design the molar is still the same place, but actually, without test, no maximum accuracy. After 5 months treatment, we start to use the class 2 elastic, and after 14 months treatment, the posterior teeth occlusion is not bad. At this time, after 16 months treatment, I prepare, go through Invisalign, and go through refinement. And let's take a look. I always leave a little space before I start to use refinement. And let's look at left side is the predict result when we when we design in clean check, and the right side is achieve the result. So even we use the compensation curve and design in our clean check, actually it's the same as you make a wire bending to make a big reversible speed in your braces case, but actually you would not like to make the anterior teeth become open by. So it's just the force system. Just remember, clean check design is a force system. It's not model setup. At this time, I leveling the couple speed. After 24 months treatment, I achieved the beta occlusion and finished this case. And then let's take a look at the airway space. I think there are not so many changes. So don't worry. I think extraction would not make the pharyngeal airway space constriction, I believe. This is a volumetric X-ray, the superimposition. Upper anterior teeth more upright, and of course the molar protraction. Upper molar protract for 4 mm, the lower molar protract for 3 mm. So in this case, my conclusion is aligner will offer the moderate anchorage if without text. Sometimes minimal anchorage. And second, bi-Brock effect will produce better vertical control than braces. Please notice, when we treat this case, if we treat this case with braces, we will make the transparatal arch and hope to have better vertical control to prevent from the molar extrude. Because the braces always, when we close the space with braces, we find out the molar always extrude. The vertical control is very difficult with braces, but in clear aligner therapy, the bi-Brock effect will make the vertical control more easy. And the aligner, the full coverage over good torque control. I mean, if the upper incisor, you want to have a better torque control, you have to make sure the aligner is all coverage. And the juvenile patient, good compliance will lead to this case, good treatment results. And I will show you the 2015 cases. This is a class 1 bimaxillary protrusion adult. And in this case, I will talk you from the profile. I think the teeth is not so crowded, but please notice this case. When I treat this adult case, I always to discuss with my patient very detailed. Why? Because in bimaxillary protrusion treatment, I find out when the anterior teeth retraction, some patients, they will ask me, "Hi, Dr. Chang, the bilateral zygoma seem become prominent than before." These words will make you a little worried, and sometimes it will make me cannot sleep, because you cannot solve this problem, and this is not your problem, because we just only retract anterior teeth. I cannot guarantee the face problem, including sometimes you find out the nose problem, or your eyes problem, or your zygoma problem, or the gonial angle problem. I'm sorry, I am an orthodontist. I just treat your teeth. That's it. And leave incompetence. Okay, that's my job. Myocardium, that's my job. So I will please discuss with your patient, especially the adult patient, when you use the extraction treatment patients bimaxillary protrusion. From the cephalometric X-ray, the upper incisor angle is larger than norm, only 7 degrees. Only 7 degrees, just a little straightened. Interincisor angle less than norm, 14 degrees. A little interincisor angle decrease. The ODI shows skeletal open bite tendency. So in this case, because the anterior teeth, the angulation almost seems normal. No. So maybe we cannot ignore a nerve talk, or you will make the anterior teeth become like this one, retrocline very severely. So in this case, I learned a lot of experiences. Okay, I removed the second bicuspid for aesthetic problem, and then I designed this clean check. This is caterpillar motion denial. And after 10 months treatment, we find out the molar mesial tipping. So I hope to use the local braces to upright the molar. After 2 months upright, I finished molar. So aligner and the local braces would achieve effective molar uprighting and prevent from unwanted premolar buccal tilting, because the aligner covers the premolar. If without the aligner and you only use the local braces to upright molar, you will find out your premolar will tipping buckling very severely. So with the liner, we find out the premolar is still in a good place. Then after 10 months, I use the segmental braces. And after 10 months, we upright molar, and I'm ready for further refinement. So before you prepare to refinement, the key point is first, posterior teeth, you have to upright it less than 5 degrees, as upright as possible, and 2 millimeter residual space, interdental space at least before refinement. You need just a little space to make maybe some angulation, torque control, or to make the midline movement. On the here, this is a refinement clean check design. I make the molar distal line and upright, and I make the lower molar projection to close the space. From this case, lower arch simultaneous movement. This will make lower anterior teeth tipping much more lingually, because the anterior teeth, the anchorage is very small, but posterior teeth, the anchorage is very strong. So it is impossible only use the liner or braces and hope to close the space and make only the posterior teeth protract much more than anterior teeth retract. So let's look. First, additional liner after 6 months later. We find out what happened. The roller coaster effect. The overbite becomes more deep, and the crown tipping distal. And the molar root torque doesn't work. It's not the same as the clean check design. Inside the root torque lingually, yes. But don't worry, because after 18 months treatment, we find out posterior open bite. At this time, I still hope the patient wearing the liner, but I increase the class 2 elastic because I hope to, if I can make the posterior teeth extrude and to make the posterior teeth contact, it will open the anterior bite. So after 26 months treatment, the posterior teeth upright, and when the posterior vertical stop is constructed, and then the anterior bite will stop here. And after 14 months treatment, the overjet and overline become better. And the 14 months treatment, and the 48 months treatment, 4 years. But we turn the table from the deep bite roller coaster effect to normal overbite with clear aligner therapy. From the profile, I achieved better deep position. And superimpose, we find out the lower anterior teeth retract much more, and the upper anterior teeth upright, straightened. Here, so today, I share the 6 cases is about very severe bimixal protrusion. And this is complex malocclusion for me. And I hope we can learn something from the 6 cases to know how to solve the unwanted effect. For example, the roller coaster effect. So please learn more about the liner and the segmental power arm. If you can understand how to use it, you will break through the limitation for complex malocclusion patients. So the keys to success for bimixal protrusion treatment is first, caterpillar motion design and the design compensation curve in your clean check. And second, please use the anchorage by TADS. TADS will offer maximum anchorage. And third, good torque control in anterior teeth and use the segmental power arm in posterior teeth. Some doctors or some patients, they always ask me about As they know from their search, Google search, some doctor told liner only used in a simple case or some different case. They don't believe they can use the trouble case or anything. I have let you know. All the borderline of limitation depends upon doctors' clinical experiences. And how to break through the treatment comes from your experiences. So understand the phrases and aligner, the treatment biomechanics is very important for every orthodontist or doctors, because understand then you will break through the limitation. At the WFO World Federation of Orthodontics, President Dr. Nick Lesh, he has published his paper, The Emperor's New Clothes. Is clear aligner is Emperor's New Clothes? I don't think so, because he told this. I think this word is very good. How open we are to catalyzing these applications will define how we chart our future. So I hope to again all odds with you all together. And many thanks my mentor, Dr. Winnership, and the Dr. Chang, and the Dr. Yao, or many my teacher in Taiwan, because of their teaching, let me have this chance to overcome this very trouble case. And I hope everyone welcome to join the Taiwan Association of Aligner Orthodontic Congress. We have annual Congress. We'll arrange a lot of very nice speakers for you. Thank you so much. Have a good night.
Thank you very much, Dr. Stephen Chang, for the interesting and informative lectures. I hope our audience tonight will benefit from your presentation. So, looking at the chat box, Dr. Stephen, there is a few questions. The first question is, may I know which is more effective in bodily space closure? Double power arm with tats or loop with wire bending?
First question, right? Dr. Hawking Chong. Yeah.
Oh, yeah.
Both. I think both is very effective in bodily movement, because I use a double power arm. I hope to make the force will more close to a center of resistance. If you can make your force more close to center of resistance, you will always have the bodily movement effect.
Okay. All right.
The second question.
All right. The second question, also from Dr. Hao, is do you put TAT in intraradicular between M1 and M2 or infrazygomatic?
Okay. It's a very good question. Thanks, Dr. Hao. The TATs, they are very different size and different lengths. It depends what kind of the TATs do you use. I use a TAT is very small. I use my favorite TAT length is about 8 months, and the diameter is 1.2 millimeter. 1.2 millimeter. It's very, very small. So I always put the TAT interreticular between first molar and the second molar, or first molar and the premolar. But I never use the infrazygomatic the screw. I know some doctors like use the IZC, but I don't use this IZC.
Okay, all right. I hope that answers Dr. Hao's questions. And the last question from Dr. Hao also is, do you see patient weekly or to replace the power chain?
Okay, let me check here. Sorry. Yeah. Okay. Yes. I replace the power. I replace the power chain every weeks because I think the power chain, the force will decay only 24 hours. You can see the power chain, the force research, and only 24 hours, the power chain, the force will decay very quickly. So I always recommend my patient to replace the power chain every week or every 2 weeks because my patient is not far from my office. Yeah. If you use the loop mechanics, it is not necessary to change the force. But please remember, sometimes we have to hold the power chain, even the power chain, the force decay, we have to hold the power chain at this length because I told you we have to make the teeth still in the place for a long time and make the PDL, the translator fiber to reorganization and to produce better torque control.
Okay, all right, thank you. I think next question is from Dr. Alice Wong. May I know how long do you put for the sectional braces to upright the molar mesial tip?
Okay, thank you, Alice Wong. Yeah. Sometimes I find out 2 months the sectional braces will make the molar upright is enough, but sometimes maybe half 1 year, 6 months, maybe 6 months you will upright the molar. And what causes molar tip? What causes molar tip? Sectional braces. I use the 016 night wire or 016 by 022 night wire and to bend the sectional braces, and it will produce enough counter moment to make the molar upright.
Okay, thank you, Stephen. And then another question just come in is from Dr. Naizushi. For vertical control, clear aligner shows better result than braces. Is it this due to full coverage by the aligner?
Oh, hey. Thank you, Dr. Nai. It's a good question. Yes, according to the published paper, the clear aligner, the aligner, they have about 1.5 thickness, and this thickness will produce enough the intrusive force, and especially not only aligner, but also you will chew, you will bite something, and when you bite, when you teeth bite, the aligner will produce the intrusive force, and it will make us easy to produce good vertical control. If without this aligner, okay, in braces cases, when we close the space, we find out in the molar, we find out the molar will not only body movement, sometimes they will a little extrude in the lower arch, and the upper teeth, they will extrude and protract. It's not the same. The movement style is not the same as clear aligner therapy. Thank you for your good question.
All right, thank you, Dr. Stephen Chang, for the webinar tonight, also for answering our question from our participants, including from Dato' Hao. Okay, and tonight, for your information, tonight we have about more than 100 attendees in the Zoom, but we also have a couple in our YouTube channel for your information. And we also got quite a number from your country, Taiwan. Dr. Stephen Chan has joined in our session today. So on behalf of section 15, I would like to thank you for sharing your expert opinion on to our participants, to our participants tonight. So we hope that your presentation tonight has been useful and fruitful for them. So again, thank you very much for joining us tonight, Dr. Stephen Chang, and we hope maybe in future be able to meet again in another meeting if possible. Okay, so thank you again.
Thank you very much.
Thank you very much. So to our participants, thank you for joining us tonight. And I just like to share with you, later on, we will have another speaker from on orthodontics. Also, this time is from Dr. Syed Faisal Shah. He is from Pakistan Orthodontic Association, the president of Pakistan Orthodontic Association. So he will, he has not confirmed the topic, but he has confirmed the date with us on the 8th of September. So see you again in 2 weeks' time with Professor Dr. Syed Shah Faisal from Pakistan. He will be the same time at 9:30 on the 8th of September. Okay, till then, we'll see you again in 2 weeks' time, and hope you have a good night rest wherever you are. And also tonight, we have, as I said, we have a participant even from joining us from Lithuania, who has logged in to register to our webinar. Again, thank you very much to all our participants, and of course to our speaker who has shared with us, and of course our president, Dr. Hao Kim Chan is here tonight, and also some of our country region also have joined us to listen to you. I think Dr. T.C. Pua, I'm not mistaken, I saw his name as one of the region surgeon Singapore has joined us. Okay, with that, I think I will end for tonight webinar, and hope to see all of you in the near future. Thank you very much, and good night, and have a good rest. Thank you. Thank you. Bye-bye, Dr. Stephen. Okay, and thank you, our education committee, Dr. Amy and Datin Dr. Mayuna, who have helped in to run this webinar, and also produce a certificate for our participants. Thank you very much. Okay.